following is a video presentation via Zoom of the Civil War Roundtable of the District of Columbia. Founded in 1951, the Roundtable hosts monthly presentations at a location near Washington, D.C., more recently at the Fort Myer Officers Club. For more information, go to www.cwrtdc.org.
I call this talk Civil War Medicine Primer. It's a Civil War Medicine 101. The gist of what I'd like to cover in this talk is what the medical advances which came out of the American Civil War were, and I'll try to cover most of those. But there are advances in prosthetics, the use of female nurses in a systemized nursing service, the birth of organized triage, which directly influenced the modern ambulance system, and of course our medical hero from the museum, Jonathan Letterman, birth of the fields of plastic and reconstructive surgery, and that's Dr. Gordon Buck, treatment of fractures, and Dr. Buck, if those of you who are physicians will know what Buck's traction is, the ligation of arteries, advances in hospital construction, the Pavilion Hospital, the advances in pain management, the surge in nerve injuries and chronic pain, marking the beginning of contemporary neurology. And that's Silas Weir Mitchell and Turner's Lane Hospital in Philadelphia, the beginning of the specialty of neurology. The use of disinfectants, the increased resources of contagion and disease transmission, your increased awareness, treatment of hospital gangrene with bromine, Dr. Middleton Goldsmith, which I'll talk a little about, treatment of mandibular fractures, and that would be Baxter Bean and Thomas Gunning. We'll talk a little bit about Thomas Gunning in relation to Secretary of State Seward. And the treatment of open chest wounds, and that's a young guy named Benjamin Howell. So when the war started, the Army had 113 surgeons, and they had an army of 16,000 men. And these guys were mostly distributed in forts on the coast, and primarily, however, out west, where they were dealing with the Indians. 24 joined the Confederate Army. They resigned their commissions to join the Confederate Army. 3 got dismissed for disloyalty. By war's end, starting with that number of under 100 Union surgeons, by the end of the war, 12,500 had served. Of those, 5,500 were civilian contract surgeons, and 2.2 million men had served. We say about 3,200 Confederate surgeons and approximately 1 million men served. Now, whenever I give talks and I talk about the Confederate Medical Department, I always have the caveat that we don't have all the Confederate records. As you know, there was a fire in Richmond in April of 1865, and the records burned. Now, one of the Confederate surgeons, Jonathan Jones, was able to copy some of those records. So before the fire, so we do have some of the Confederate records from the East. We do have more complete records from the West, but we do not have anything nearly as complete as we have for the Union. Now, my friend Michael, he correctly asked me a question about am I going to talk about African American surgeons? And up until recently, I had not, but he's totally right that they need to be mentioned. Okay, so at the time of the war, only 10% of African Americans had attended medical school, as opposed to 2/3 of the white physicians. There was an apprenticeship expected for both groups, and at least 13 African American physicians served in the United States Army during the war. 2 had attended medical school but had not received their degree when they received their appointments as acting assistant surgeons, and all served with the United States colored troops in various freedmen's hospitals working with African American patients, or were involved in the recruiting of U.S. colored troops. So I would mention, first of all, for those of you who don't know what I'm talking about when I'm talking about acting assistant surgeons or contract surgeons, acting assistant surgeons were individuals, both white and black, but primarily, of course, white, who were given contracts anywhere from 3 to 6 months to work primarily in the general hospitals, not so much in the field. And they were given a contract, and that's what they did. Now we're going to go back 2 slides because I want to talk about 2 of the most prominent of the 13 who served. And by the way, what happened was one of the reasons they didn't serve in the field, because just the sign of the times, is the white surgeons, the African-American regiments had black officers. In addition, they had white surgeons attached to them. The white surgeons would not serve with the African Americans. They did attempt to send some of these guys out into the field to serve with the African American regiments. However, the white surgeons refused to serve with them. Two of the guys who we talk about the most in this field, in this context, are Alexander Thomas Augusta. He was born in Virginia, and he was a graduate of the University College of Medicine in Toronto. A lot of these guys had to be, obviously, none of them graduated from U.S. medical schools. The first African-American to be commissioned as a major or a surgeon in the Union Army, subsequently promoted to lieutenant colonel. Surgeons, by the way, held the rank of major. Each regiment would have a surgeon and 1 or 2 assistant surgeons. Surgeons had the rank of major. Assistant surgeons had the rank of captain. And in the Confederate Army, they could be also lieutenants. So that's how that worked. This guy was appointed to head the Freedmen's Hospital in 1861, thus becoming the first black hospital administrator. In addition, he was the first African-American after the war to be appointed to the faculty of Howard University, once Howard started. Interestingly enough, the faculty at Howard when it started, was primarily white. So this guy actually turned out to be the first African-American to be on the Howard faculty, medical faculty. And of course, where the Freedmen's Hospital was in 1863 in Florida Avenue is very approximately where the Howard Hospital is today. And the other surgeon we talk about is Anderson Ruffin Abbott. Now, Abbott was Canada's first African-American medical graduate, graduating also from Toronto, and he actually studied under Augusta. And he initially served with a black regiment, but of course, after the white surgeons wouldn't serve with him, he was transferred. He requested a commission as an assistant surgeon, but he was denied that. So he served as a civilian contract surgeon in various hospitals, including the Freedmen's Hospital again, rising to the position of surgeon in chief. He was the chief surgeon. Augusta was the guy who ran the entire hospital. One of the doctors in attendance, he was also one of the doctors, there were 16, by the way, at the Peterson House following the assassination of President Lincoln. Now, he happened to be good friends with Elizabeth Keckley, and he was the one who actually accompanied Elizabeth Keckley that's Mary Lincoln's friend and dressmaker. He accompanied her to the Peterson House. In appreciation, Mary presented a shawl worn by President Lincoln at his first inauguration. She presented that shawl to Anderson Abbott. And he, I believe, I know that Augusta also went to the White House about the same time Frederick Douglass did, and I think both of these guys both went to the White House also. Okay, now we're going to start talking about Civil War casualties. There were 750,000 deaths in the American Civil War. Those of you who've been around this for a while used to hear the figure 620,000. But no, it's been 10 years maybe now, or at least 5. That number has changed, and what they did is some researchers went back and looked at the census from 1860 and 1870, and they were able to ascertain that the actual number was closer to 750,000 deaths. There are over 1.2 million casualties, and there are 6 million cases of sickness. Now, the thing that we always emphasize when we talk about Civil War medicine is that of all the deaths in the American Civil War, 2/3 were from disease. The number one killer was dysentery. That killed 45,000 Union soldiers alone. And it killed about an equal number of Confederate soldiers. Out of 1.5 million cases and 50,000, so it actually killed more. It killed about 50,000 Confederates. This was followed by typhoid fever, which was 27,000 Union soldiers out of about 75,000 cases, and it killed about 30,000 Confederates. Even though the Confederates had fewer guys in the total in the Army, you can see that they had slightly more deaths. And the reason being, of course, is their diet, their sanitation overall was less than available to the Union guys. It was not that the Union doctor, the Confederate doctors were any less competent. They were always, however, deficient in supplies and sanitation and just general things in general. So they were always under a tremendous handicap versus the Northern surgeons. Now, like I said, disease was the number one cause. So in the Union Army, these are older figures here based on the older 620,000 figure, because this slide's a little old. To give you the proportion, we had in the Union side 110,070 death wounds, and 250,000 died of disease. On the Confederate side, you had 94,000 from the battlefield and 164,000. But when they had the larger figures, those numbers went up proportionally. As I intimated, the medical supplies were always at a deficiency for the South. But the way the supplies were transported, they were brought to the war front. Ammunition was sent first, then rations, then medical supplies. The classic example of this was Gettysburg, where General Meade ordered the ammunition wagons forward, and he made the medical supplies. He did allow the ambulances onto the field, but he required that the medical supplies stay at the Union supply base 25 miles away in Westminster, Maryland. So the Union Army at the onset of the battle, during the battle, and immediately thereafter had a real problem with their medical supplies. It was true for all the units except for the 12th Corps at Gettysburg. The 12th Corps medical director basically defied the orders. He said, "It's BS, we're not doing that." They had their medical supplies. The surgical instruments were used on one soldier without much more than cleaning with water. People ask, how did they disinfect their instruments? Well, the answer is they didn't. The instruments had ebony handles, mostly made of wood, and those, of course, were not sterilizable. You can't sterilize wood. It did not matter because they didn't sterilize their instrument. When we talk about nurses, there are two that we talk about the most probably would be Clara Barton and Dorothea Dix, although I'll tell you a little bit about Clara. She's not technically a nurse. At the outbreak of the war, the Army nurses consisted of barely trained men. As I said at the beginning, one of the advances was the introduction of females into the nursing profession. Actually, the first nursing school did not start till after the Civil War, and that was at Bellevue Hospital. Approximately 3,000 women in the North. That figure is low. I think that figure of 3,000 would pertain more to the North, but we don't know the exact number in the South, but there are thousands of women who serve. Dorothea Dix was responsible for the Union Army Nurses Corps. She was actually given that commission by President Lincoln and through Stanton. And Dix about 15% of all the nurses in the war were recruited by Dix. She was an interesting character. Her nickname was Dragon Dix. She had started in the mental health field, very involved with the starting of St. Elizabeth's Hospital, actually, here in DC. She stated that she only wanted so-called plain-looking nurses, which means ugly women, because they were, the Victorian sensibility about the men being attracted to the women. That got violated, however, a lot. But she was highly efficient and generally did a good job, but she clashed a lot with the superiors. Clara Barton was not technically a nurse. She was much more of a purveyor of medical supplies and an assistant to the surgeons. She actually assisted in surgery. At one episode at Antietam, she actually removed a bullet from the cheek of a soldier with her penknife. But she was very instrumental, especially early in the war, in making up for some of the deficiencies the government had in providing medical supplies to the surgeons. Clara Barton was not associated with the U.S. Sanitary Commission. In fact, early on, they sort of worked, they were competitors at least. But both of them were involved in providing relief and providing supplies, filling a void that the government was really, especially early in the war, unable to fulfill. So it was created in 1861, somewhat over the objection of Stanton, who called it Lincoln, the fifth wheel. We need to see, he said, the Sanitary Commission, we need as much as a fifth wheel on a coach. In fact, there's a book written called Lincoln's Fifth Wheel, and they call that the Sanitary Commission. They believed that the government did a poor job of taking care of the health, comfort, and welfare of the soldiers, which was true. So they volunteered. Although interestingly enough, they had paid agents. The Sanitary Commission had a paid staff. The guys who were the people in charge of the Sanitary Commission were men. The people who did most of the work were women, not surprisingly. Although there were male Sanitary Commission agents as well. One of the prime movers, actually the treasurer of the Sanitary Commission, was a guy named Olmsted, as you know, Olmsted, who is the designer of Central Park and of course of the U.S. Capitol. That Olmsted was Frederick Law Olmsted was very involved in the institution, in founding of the Sanitary Commission. So they raised money through a series of sanitary fairs. They raised $100,000 even in the Western Fair in Chicago. They actually, Abraham Lincoln donated a copy of the Emancipation Proclamation, which was auctioned off in one of the sanitary fairs. And they also operated soldiers' homes, lodges, or rests for Union soldiers. And you can see pictures there of some of the Sanitary Commission people. And these are the fairs that I was talking about, the sanitary fairs. You have a poster there, sick and wounded soldiers. The Chicago Fair was one of the big ones, but they had them in most of the major cities, Cincinnati, Philadelphia, New York. And some of these were really elaborate affairs, as you can see from the pictures there. They had very fancy restaurants inside. They had things you could buy, and they were quite elaborate things, and they were really big social occasions when they held these sanitary fairs, and they were able to raise lots of money for the Sanitary Commission. So the next is we're going to talk about treatment of disease. Like I said, 2/3 of the deaths in the Civil War from disease. When we think of a Civil War surgeon, we think about the guy with the amputating knife and this capital amputation saw. However, the guys, actually, the doctors, the surgeons, spend much more of their time actually treating disease, doing sick call, and that kind of thing than they did cutting off arms and legs. Okay, so the treatment of disease, that's based on the theory that excess stimulation of one's body could cause overexcitement. This was known as inflammation, and that's the so-called Brownian theory. So therefore, the treatments that they prescribed is based on countering the inflammation by bleeding or purgatives. So that's the medicines that are calomel and blue mass, calomel being tartar emetic, blue mass being mercury. These are poisons, of course. Cathartics like podophyllin, we still use podophyllin. Diaphoretics, which is tartar of antimony, opium, and ipecax. Narcotics or counter irritations, which is cupping. That's how they treated pneumonia. Medicines were largely heavy metal based. And so I have a thing called the Squib Medical Panier, which contains 52 tins of different medicines. And of those, the only thing in there that only about 6 of them were of any use. And the only medicines that really were of any use by modern standards were quinine for malaria, chloroform and ether for anesthesia, and topical bromine for hospital gangrene. Now, they did have some other medicines that had some utility. They were able to, they had some anti-inflammatory drugs that were agents that were able to, they used them for arthritis. They, of course, didn't have aspirin yet, but those that I mentioned there were the primarily ones that were effective. The problem being is they didn't recognize that they were giving these medicines and they were causing all kinds of horrendous side effects. Mercury, of course, can cause salivation, separation of the gums from the teeth, facial lesions. It actually can cause neurological side effects. And some of the suicides which occurred and the neurological deterioration of these men that occurred after the war, some of it was PTSD, we think, but some of it was actually the effects of mercury. President Lincoln himself, actually, as a young man, received mercury, and then he was depressed, and that, of course, can be a side effect of mercury as well. Of course, they gave mercury to people who were depressed, so it got a little, the situations got a little complicated. But the real point is that these guys were in some ways poisoning their patients. Now, there were surgeons like William Hammond, who was in 1863 appointed Surgeon General, who was sort of forward thinking. He tried to get rid of some of these medicines, but things do not change, as the doctors in the group will tell you. When he tried to institute change, he met with tremendous backlash. He was accused falsely of misappropriation of funds, of mismanagement, and he was actually court-martialed. He had to resign. He was fired, and he actually was court-martialed. Later on in the 1880s, he cleared his name. He was vindicated, but very, very strong resistance to trying to change these practices. So we're talking about the Brownian theory of medicine, and this is based on the theories of a guy named John Brown, who lived from 1735 to 1788 in England. And he believed, as I had intimated earlier, that excessive stimulation, which is called the sthenic state, from the Greek for strength, that caused indirect debility. The other side of the coin, you had deficient stimulation, which is called the asthenic state or direct debility. So therefore, as I had said earlier, the Brownian theory of medicine, which is what the mainstream Civil War surgeon practiced and what he was taught in medical school, was that you either had to, depending on the disease either caused overstimulation or excess or understimulation. So you either had to stimulate the system or bring it down. And of course, that's the primary rationale for the use of so much medicinal whiskey. Union Army used 1.9 million 32-ounce bottles of medicinal alcohol in the war. If you're wounded on the battlefield and you're felt to be in shock, the first thing the surgeon's going to give you is, after maybe some opium or morphine for the pain, is some whiskey to stimulate your system. Of course, that's the absolute last thing you want to do. Alcohol being a depressant, but they did not know that. So the Brownian therapy, here's what you did if you felt that you had to lower the system. That's the aesthetic treatment. There should have a name off of it. One is gentle cathartics, vegetarian diet, watery drinks, bleeding only in the most severe cases. I should mention that by the time of the Civil War, bleeding, like you would equate to something like was used with George Washington, that wasn't done anymore. They did use what was called scarification, where you'd make small cuts in the skin, and that was still used. But massive bleeding and purging was not done. Cupping usually was a treatment of pneumonia. Cupping, which is still in some forms even used to this day, was the basis for cupping was that you had to create a count, say for pneumonia, which is inflammation in the lungs, you had to create a counter inflammation to then draw the inflammation out of the lung. So what they would do, there's two kinds of cupping, dry cupping or wet cupping. Dry cupping, you simply create a suction on the chest. Wet cupping, you actually heat these glass cups up. You put them on the chest, you create a second-degree burn. That forms a blister. You then lance the blister. And so that was the theory. And in actual fact, what it did is nothing except give you a second-degree burn. The aesthetic treatment, that you shouldn't have an A there, is rich foods, liquor. Like I said, 131 million ounces in the Union Army because that was a stimulant. Things like camphor and opium. So those were the treatments where you're trying to stimulate the system. If you had something like typhoid fever, they'd want to stimulate your system. Again, you can see what's wrong with all of these things. For example, if you had diarrhea, they give you mercury's a purgative, right? So that the idea was you wanted to get the poisons out of the system. So they give you mercury. What does that do? Cause more diarrhea. So all the medications that the Civil War surgeon used were designed to make you vomit, sweat, urinate, or defecate. So therefore, it is no surprise why in many instances, the troops were more afraid of the doctor than they were of the enemy. So we've covered, I think, at least cursorily, what the treatment of disease was like. So here's what most people think about when they think about Civil War surgeons. Civil War gunshot wounds, we're talking about 110,000 reported in the Union and 94,000 in the Confederacy. 94% were gunshot wounds. 75% were to the extremities. The mortality was about 13% in the Union Army, questionably 20% in the Confederate Army. I don't think it was really that high. I think the Confederates did better than that. Now, when we talk about this, you think about the kind of weapons, and we're going to talk about mini balls and so forth. First of all, why do we know so much about the Union? Why can I tell you with pretty good accuracy, 94% were gunshot wounds. And why were so many gunshot wounds? Because that's what they could treat. Think about it. If you get shot in the gut, you get shot in the head, the abdomen, high mortality. What can a surgeon do? He could remove the bullet. That's about it. There's no intestinal surgery of any type done in those days. They didn't really operate on the lung. So you were basically, in many, many cases, going to die. So therefore, the surgeon would put you aside. They actually had a thing called the dying tree in many places where those cases were triaged to. But gunshot wounds to the extremities, and that's why you got 75% extremity there, that's what the surgeon could treat. And that's what showed up in the hospital statistics. And why do we have these statistics in such accuracy? That's because of a thing called the Medical and Surgical History of the War of the Rebellion, which is a 3,000-page, 6-volume study, which took about 18 years to write. describing basically everything that happened medically in the American Civil War. And so we have very, very good, and that has not only the excuse me, the statistics, it also has charts, it has diagrams, it has pictures, and of course they doesn't have x-rays because they didn't have x-rays, but that was written by and large at the National Museum of Health and Medicine, which is where I'm docent today. It was called the Army Medical Museum back then, and that's what the museum was started for. It was started to collect this data, and therefore surgeons were required by the curators in the museum to send specimens to the museum and to provide detailed case reports with those specimens. And now today, we have a lot of those specimens on display, which of course is only the tip of the iceberg. A lot of the stuff is in the collections, but I get to actually talk in the old days when we gave tours, show people all kinds of specimens of Civil War gunshot wounds based on that system. Of course, we talk about amputations a lot. That's the sexy thing. So they did 30,000 amputations in the Union Army. 80,000 anesthetics were administered. So that means they used anesthesia about 50,000 times for other things. And the primary agent used was chloroform in the field, and that was used in at least 75% of cases. And I think that number is too low. I think it's more like 95. The chloroform had the advantage in the field of being stable and not flammable. Ether is flammable. Chloroform is not flammable, but and therefore in the field, the surgeon preferred chloroform. The average time was under 15 minutes to do one of these operations, and it really depended on, number one, how many bleeders they had to tie off. And of course, you got to think that in some cases they had to amputate more than one limb, but a good surgeon could do one of these things in 9-10 minutes, assuming they didn't have a lot of bleeders to tie off and they were only amputating one limb. The overall mortality, believe it or not, was 26%, but it depends on the location and timing of the procedure. So why would you do an amputation? And they actually had indications for doing it. These were not done in some haphazard or random fashion. In fact, once Jonathan Letterman came in as the medical director of the Army of the Potomac, he actually put a system in where he had surgeons decide if he needed an amputation, and then he would find the best surgeons with the surgeons with the best dexterity, not necessarily the most seniority, to actually do the operations. So you would have one surgeon or group of surgeons decide if you needed the operation, and then maybe a different surgeon would be doing the operation. But the indications generally were a bullet wound through a joint, an injured blood vessel, or a bony fracture from a bullet wound. And that means what we would call today a comminuted compound fracture, which means a fracture where the bone is shattered. And principally if it's sticking up through the skin, but it also the primary thing is, does it shatter the bone? And we'll talk about why that happened in a minute. And we talked about anesthesia, and that was ether and chloroform, and I gave you the statistics. And keep in mind that when you give chloroform, it causes muscle contraction. That's called the state of excitement. So what happens is the attendants will have to, many cases, hold the patient down. In addition, you're only giving enough anesthesia to render the patient insensible to pain. So therefore, because if you give too deep of an anesthesia with chloroform, you'll kill him. It's toxic. So therefore, the patient may be moaning, groaning, babbling during the operation. I have actually read diaries of soldiers undergoing amputation where they say, I heard the bone sob, but I couldn't feel the pain. Even Stonewall Jackson, one of the most famous amputations in the war, stated, "I heard music," and what he was talking about is he actually heard McGuire's saw when he was amputating his arm. So we know, therefore, that when you see these reports of people being awake during surgery and being held down by the attendants and therefore anesthesia not being used, that's how those stories got started. It's not because they didn't use anesthesia. And of course, Hollywood movies like Gone with the Wind and The Horse Soldiers and some of these movies with Jon Willen gave the false impression that the Civil War surgeon operated without anesthesia. And you can see there two of the methods by which it was administered. One is the so-called ether cone, which is a copper cone with a sponge in it, where you put the chloroform or ether in there and hold it over the mouth. One of the ways the Confederates devised to try to conserve chloroform is the so-called Chisholm inhaler, which you see there. It was invented by a guy named John Julian Chisholm, a Confederate Army surgeon from South Carolina. And unfortunately, he didn't come up with it till December of 1864, but that only needed 1/8 of an ounce of chloroform. And it had a sponge and a wick inside, and you can see you put only 1/8 of an ounce. It had that disc, and you just put the prongs in the nose. And that was to conserve chloroform. Like I said, he didn't come up with this until December of 1864. The Confederates at that point had limited manufacturing capacity, so they didn't really use it too much till after the war. There was a northern version of this thing. Primarily, it did get used in the North, but like I say, it got really caught on a lot after the war for military and civilian use after the war. Analgesia was primarily morphine and opium. So the Union Army gave 10 million ounces of opium and they used 30,000 ounces of morphine. And like I've already told you, that alcohol was a stimulant, not an anesthetic, where 131 million ounces were administered by the Union Army. So, and by the way, the Confederacy had their own distillery to supply medicinal alcohol to the Army. The Union, they contracted it out to private firms. All right, so the question I always get is, why did they do so many? I told you they did 30,000 in the Union Army. We think that at least 20,000 were done in the Confederate Army, maybe more. So here you see a couple of pictures of amputations. Most of these are posed pictures. It wasn't that they weren't really doing an amputation, but normally you would not have spectators like this watching an amputation. They didn't have that kind of medical personnel that they would have spectators when they were doing amputations. So these were posed pictures. The one on the left, by the way, that's at Camp Letterman at Gettysburg, which was the large general hospital, which opened up after the Battle of Gettysburg. They had the capacity to treat about 3,000 patients at Camp Letterman. Okay, now the mini ball is called the mini ball, not because of the size of the ball. It's about 68 caliber, but it was named after its inventor, Claude Etienne Minié, of the French Army, who in 1847 invented that mini ball. And you can see, most of you guys know about this because you're Civil War buffs, but you see it's a generally 58 caliber fired from the rifled musket. It's concave at one end. It's rifled. That one in the picture happens to be a Union mini ball because it's got 3 rifles. The Confederate mini ball had 2 rifles. But you can see on the left, that's what happens when the mini ball is expended. It goes from that nice concave shape into sort of a mushroom shape. It becomes about 90 caliber. So if you picture what that's going to do when it comes up next to a bone, it splays out and shatters the bone. It often will embed in the tissue. Well, what's that going to do? That is a perfect setup, of course, for infection. Keep in mind that the first thing the soldier does when loading the musket, he's got to bite down on the powder cartridge, contaminating it with saliva. It's going to go through his uniform. which is contaminated with dirt and other foreign bodies, which can be driven into the wound. Remember, there's no antibiotics, of course, and there's no sterile procedures used. So you're going to get infection in these wounds. And early on in the war, they learned that if they didn't operate within the first 48 hours, the mortality would double. So you got to operate early and you got to operate quickly. So that was the lessons learned early in the war. That's the example of hospital of gangrene, but we'll go on to the next one. Now, the reason I'm talking about Napoleonic tactics here is because that explains why you had so many wounds so many extremity wounds. When you had smoothbore rifles, which were used during the Napoleonic Wars, those had a range of about 100 yards. They actually had a pretty large caliber, those balls, but they were round and smooth. So when they hit something like bone, they didn't shatter it. They would either embed in the tissue or pass through. So you didn't have that kind of consequence of the smoothbore. But they were inaccurate. Like I say, these things are accurate only up to 100 yards. So you have to mass your firepower. That's what Napoleon taught. Mass your firepower to be effective. You remember movies like The Patriot, where you see how in the Revolutionary War, the way they would mass their firepower using smoothbore muskets. And of course, you've seen what they did in the Napoleonic Wars. Well, in the Civil War, the technology had advanced to what we were just talking about with the rifled musket. The problem is the tactics had not, because most of the guys were West Point trained, and what they taught at West Point were Napoleonic tactics. So therefore, they, especially early in the war, when you're practicing these kind of tactics, but when they rifle the smoothbore, you know, we used to teach that the smoothbore was accurate up to 300 yards. Well, it's not. The smoothbore will be accurate maybe up to 250 yards if it's properly aimed. And that means when you fire a smoothbore musket, it has a parabola shape. It goes up and down. And if you don't compensate for that, you don't aim the rifle low, it's not going to be accurate. So when you talk about accuracy of rifled muskets, that's assuming you have a trained rifleman. It is not assuming that you have some raw recruit or guys who are barely trained, which a lot of them, especially early on, were. So it's not quite the accuracy that we talk about, but it's still much more accurate than the smoothbore. So here's what a Civil War amputation kit would look like. The Union Army, the government did provide these kits. Each regimental surgeon would have one of these kits capable of doing any kind of major operation. They had these nice wooden cases. They, unfortunately, however, were lined with this nice red plush velvet. Of course, that's a wonderful breeding ground for bacteria and other microbial agents. Of course, they didn't know that. And you can see what I was talking about, the handles, those are mostly ebony handles. Some of the higher ranking type guys had ivory or pearl handled instruments like Hammond. You know, they probably never used them that much, but they had all these fancy cases. But that's a typical capital amputation set. The saw you see there is called the capital amputation saw. And you can see there's a tourniquet, there's various amputating knives. The fish hook looking device is called a tenaculum, which is used for tying off blood vessels. What the surgeon would do is hook the blood vessel on that thing, slip the suture over it, and tie it. And that's just another view of what you would find in one of these kits. But this one has some other stuff in it. It's got these trocars, which you can see on the top to drain fluids like from the lung. Also has catheters. Their urinary catheters, unfortunately, were metal. So you wouldn't want to be catheterized if you could avoid that. Joshua Chamberlain was a victim of that, leaving a catheter in too long. After he was wounded at Petersburg in 1864, he developed a called a urethro-cutaneous fistula. Those doctors in the audience will know what that is. So whenever he urinated, it came out the middle of his penis. It's because he was shot through the pelvis and they put a catheter in, which they left in too long. So Chamberlain was plagued with that plus urinary infections, which throughout the rest of his life, with ultimately some 40 years later resulted in his death, because he died from kidney failure from repeated urinary infections and obstruction of the urinary tract. And then what a surgeon would carry to the field, especially an assistant surgeon, was called a pocket kit or a roll-up kit. And you could see that kit there. And that is what they would use to do various minor surgeries. You could even amputate maybe a finger or a toe. You could lance a boil. You could do all kinds of you could suture up a wound, do all kinds of minor surgery with the pocket kit. So people say, what was the mortality for amputation? And I always tell them, well, that depends where and when, okay? So like I said, if you operate within the first 24 to 48 hours, that's called primary amputation. That mortality goes up to a third to a half if you wait over 48 hours. The rule of thumb is the farther from the body, the lower the mortality. The upper extremity has a lower mortality than the lower. It all has to do with blood supply. So if you have to get an amputation, the best place is in the finger. Worst place is in your hip joint. That's got an over 80% mortality rate. That's the operation that John Bell Hood survived, however. So the amputation mortality, you can see there on the chart, it's around, for example, below the knee amputation had about a 33% mortality. The leg there is below the knee, so that's about a 33% mortality. The aggregate figure is 26.3%. So if you think about this, I always say, I am amazed that in the aggregate, about 75% of people survive these operations, considering they're done barehanded with no aseptic technique. Almost all the stumps get infected. So to me, it's a real tribute to the human immune system, if nothing else, why so many more people survive these amputations than didn't. And I just talked about what the difference between primary versus secondary. It's about a third more, 27 versus 38%. And there are two types of amputation. One is the circular, which is preferred for some reason by the Confederate surgeons. It was faster. However, it was more difficult for fitting of a prosthesis. And you can see from the way it's done, it's basically done by taking your amputation knife and just making a circular type of guillotine amputation. So it's much faster, but it is not as easy to do an amputation, to do a fit of prosthesis. Okay, a flap amputation, which was preferred by the Union surgeons, took longer. It was more difficult. But it was actually harder to protect the stump when you transport it, but it was better for fitting the prosthesis. So the way a flap amputation is done is you're going to create flaps of tissue which come down over the stump, which will then fit down over the prosthesis. And principally, you can see the way it's done in the top picture there. The type of knife used is called a Catlin, C-A-T-L-I-N. It is a amputating knife that is sharp on both sides, as opposed to the Liston, which is done for the circular amputation, which is sharp only on one side. And the way it's done is, after you cut down through the skin, down through the muscle, you're going to create the flap by putting that knife, which is sharp on both sides, creating an anterior flap. You come up, and without taking it out, because it's sharp on both sides, you can come down. You then create the posterior flap like that. You come up, and you come down, and then your assistant retracts the the stump. You then saw off the leg. And then you have a whole series of steps you have to perform. You have to first identify and tie off bleeders. And when you do that, you leave the sutures with silk suture 1.5 inches out of the wound. And that's because about 10 days later in the general hospital, the surgeon's going to come by and tug on those sutures and pull them off. They didn't have dissolving sutures. If they guessed wrong, they had a problem. In addition, you have to use a bone file to smooth the stump and bone nippers to get the little spicules of bone off, because you want that thing nice and smooth, or else it's going to have to be redone. And you want all the fragments out. They actually had a brush to get all the bone fragments out, and therefore you wanted the stump nice and smooth. And then you had to tie off, as I said, you had to tie off the bleeders with the fish hook-like instrument called a tenaculum. The surgeon would preload the tenaculum with silk suture so he could just slip it, you hook it, slip it on. You could grab it with an artery forceps, slip it on, tie it off, and like I said, leave it outside the wound. These guys got very good at this after a while. I've done a whole lot of these over the years, but mine are all fake. I once told an orthopedic surgeon who's a licensed guy at Gettysburg, I said, I've done more of these than you, but mine are all fake. In order to stop the hemorrhaging, they would pack wounds with astringents or chemicals, which would often cause more harm. They had all kinds of things like iron filings. They had silver nitrate was one of the big astringents they would use to stop bleeding. But it was expected that wounds would fester or drain pus. And indeed, when you close the stump, you leave the suit, use wire or adhesive plaster strips, and you leave those 1/2 inch apart. Why? Because it is expected that those stumps are going to drain pus. In fact, they had a term called laudable pus, which when we do it for your reenactments, we'll take vanilla pudding and put some mix it with yellow mustard. And so that's what it looks like. It's Staphylococcus for you doctors, Staph aureus, which actually means gold. And so that's why it's yellow. And that pus, generally the patient would survive. And so that's why they use the term laudable pus. They actually thought it was part of the healing process. If they didn't see it, they thought there was a problem. Now they had another term called malignant or oncorous pus, which was, it looks like brown dishwater. And that pus is caused by streptococcus, so-called flesh-eating bacteria. And they knew when they saw that, which is why they call it malignant pus, not going to survive. So they did have some idea what was going on, what the actual etiology was. I should say they did know that bacteria existed because they had microscopes. And of course, that went from the late 1600s. But in fact, in the general hospitals, they issued microscopes to all the surgeons working in the general hospitals. So they used microscopes, but they did not use them the way we use them today. Now, the other thing when we talk about medical advancements of the American Civil War is the prosthetic industry. And that really got a huge boost in the American Civil War. Okay, so one historian estimated that the war debilitated or disfigured over 600,000 people. In 1867 alone, the federal medical authorities purchased 4,000 prosthetic legs, 2,391 arms, 61 hands, and 14 feet. In 1866, Mississippi spent half its budget on artificial limbs. So what happened after the war? The federal government set up a program, a voucher system. They contracted with one or two prosthetic makers, and they allowed you to spend $75 for a leg and $50 for an arm. You went with your voucher and you could get that prosthesis, the standard government issued prosthesis. if you wanted more, a fancier one, then you had to shell it out at your own expense. So it's like nothing changes. The guys with more resources got the better prosthesis. In the South, though, of course, the federal government was not going to pay for artificial limbs for Confederate veterans. So each state had its own prosthetics program. And you can see in Mississippi, they spent over half its budget in 1866 just on artificial limbs. I've seen similar figures in the state of Georgia as well. Those of you who know Bob O'Connor, I think we had him as a speaker one time. Bob has a book. One of his books is a biography of a guy named James Hanger. James Hanger was a Confederate private whose left leg was shattered at the Battle of Philippi, June 3rd, 1861. His leg was amputated by Union surgeons and fitted with a prosthesis. He didn't like that prosthesis, so he went home, constructed a new prosthesis of barrel staves and metal with hinges at the knee and foot. Ultimately commissioned to construct prostheses for wounded Confederate surgeons. Today, the Hanger Prosthesis Company is worldwide, sees over 650,000 patients annually. It was owned, I think, until the 1930s or so, maybe even longer than that, by the family, Hanger's descendants. Okay, anyhow, so Hanger Prosthesis, they have places even here and all over the country, really all over the world. They're still in business. They're still providing prostheses to people to this day. It's a huge company. And that's what one of these prostheses would look like, with the movable ankle and leg and knee. Okay, so here's one of my heroes from the Civil War, Jonathan Letterman. He was the medical director of the Army of the Potomac from 1863 to 1864. He established an aid station at the regimental level. Aid stations were principles of triage were instituted. Letterman established mobile field hospitals at the division and corps levels. He was the guy who came up with the ambulance corps in the Army of the Potomac on August 2nd, 1862, under the medical staff. Previously, the ambulances had been under the quartermaster corps and was frankly a disaster. Early on, they contracted ambulances, say at First Manassas. Most of those guys, when things went south, took off. At Second Manassas, a lot of these guys were drunk. It wasn't until Letterman came in and established the ambulance corps, which in 1862, which really turned things around. He arranged an efficient system in the distribution of medical supplies as well. And he did the triage, the field aid stations, the whole system, which to this day is being used by the Army in Afghanistan, by the military. The Letterman system is still in place. They have substituted the helicopters for horse-drawn ambulances. And they do have the ability through these large cargo planes to transport guys very rapidly from Leinstuhl in Germany, which is where they get sent from Afghanistan back here to Walter Reed. And Civil War ambulances, of course, were horse-drawn ambulances. There were four-wheeled and two-wheeled, four-horsed and two-horsed. There were a whole bunch of them. A lot of them were not very good, but the best one designed was done by Daniel Rucker. Daniel Rucker being the assistant chief quartermaster of the Union Army, sort of Meggs's right-hand man, guy who helped Clara Barton get onto the battlefields. She worked a lot with Rucker. But one of the Ruckers, and he was also present at Lincoln's autopsy, but one of the things Rucker did was design the Rucker ambulance. This is a famous painting of a field hospital at the Pry Mill Museum, Pry Mill Hospital at Antietam, September 1862, with the ambulances coming in. You can go to Antietam to this day, that building is still there. The other thing that came up later in the war the Union Army came up with the Autenrieth medical wagon, which is basically a pharmacy on wheels. You can see all the medical supplies you would ever need are contained in that medical wagon. And this is there are several ways that you carried supplies to the field. One is a surgeon's field companion, which you could actually wear. It had straps. You could wear it over like a knapsack. You brought it out onto the field, which contained various dressings, bandages, medicines. And then Squibb, R.J. Squibb, who had been a naval surgeon in the Mexican War, resigned his commission in the 1850s and opened up a drug company in Brooklyn called the R.J. Squibb Company, which of course is still there to this day. It's now called BMS Squibb, Bristol Myers Squibb. But at the time of the war, he came up with the Squibb Medical Pannier, which he sold to the Army for $100 each. This contained 52 different tins, most of them medicines, but it had other things in like coffee, tea, olive oil, alcohol, 200% alcohol for making, or 100% alcohol for making tinctures. It had all kinds of stuff in there. And I talked about what was worthwhile in there that worked were mostly the pain medicines, and had digitalis actually, which did work, and the medicines for gout and anesthetics were the things that work. So that's the Squibb Medical Pannier, and I actually have a repro, one of those, which I bring to reenactments. And that's just another shot of the original U.S. Army Medical Pannier with all the tins in it. And Squibb actually made a fortune during the Civil War selling drugs to the Union Army. But he joked that the guy who was his greatest distributor of his drugs to the Confederate Army was Nathaniel Banks, because General Banks had the habit of having his supplies captured by the Confederates. So Squibb said, the guy who did the most to distribute my drugs to the Confederacy was Nathaniel Banks. And these are just more medical knapsacks. My compatriot in the Blue and Gray Hospital Association, Mark Quattrock, actually the president of our group, this is his thing, is all these different things. He gave a whole talk just on the medical knapsacks and the panniers and things like that. Okay. The Civil War hospital ship was used. It was used primarily in the Peninsula Campaign, where the Sanitary Commission had hospital ships. It also was used out west, where obviously you had rivers that were amenable to having hospital ships. And so you see one on the left called the USS Red Rover, and that of course is the interior of one of these hospital ships. And we had at the museum in Silver Spring, just last December, we put in a Civil War hospital ship exhibit. And of course, this now has relevance today because the USS Comfort and the USS Mercy were deployed during COVID-19, the Mercy being deployed to New York and the Comfort to Los Angeles to assist with the pandemic. And those are descendants of these Civil War hospital ships. Of course, the Comfort and the Mercy got 1,000 bed capacities each. They also had the Civil War hospital train, which you can see there, and the interior, and they had kitchens in these things and stoves, and some of them were quite elaborate. And they were supposed to fly the hospital flag so the enemy would not fire on them, which held up most of the time, but not always. Now, one of the advances of the American Civil War is in facial reconstruction. And this is Dr. Gurdon Buck, who came up with Buck's traction in 1861. But Dr. Buck also performed 30 facial reconstructions. And he had a hospital in New York. And he is sort of the father of plastic surgery. And most people don't think about that being done during the Civil War. But Buck did 30 procedures. And one of his more famous patients was a guy named Carlton Bergan. And Bergan was not shot in the face. He did some guys who were shot in the face. This guy got mercury because he got pneumonia. He developed pneumonia, he was given mercury, and he developed one of the side effects of mercury, which is dehiscence of the gums, facial and oral ulcerations, and facial disfigurement. And he performed a series of surgeries and restored his face after receiving the mercury. One of the other advances is in dental prosthesis, maxillary jaw splitting. And there were two. There was Dr. Baxter Bean, who was a Confederate. He developed a splint for the treatment of the maxillary jaw fracture called the Bean splint. And he had treated over 100 cases in Atlanta and later in Richmond. In Atlanta, he actually had an entire section of a hospital devoted to his cases. Dr. Thomas Bryan Gunning was the Union counterpart to Bean. He was a New York dental surgeon who devised a splint for jaw fractures. He probably copied it from Bean, and he was the guy who treated Secretary of War Seward after fracturing his jaw in a carriage accident. And those of you who are Lincoln assassination aficionados know. Then when Lewis Powell attempted to kill Secretary Seward with a big knife, with a Bowie knife, by stabbing him in the neck, he was going for the jugular vein. He was unable to do so because Seward had had a carriage accident, and Gunning had treated him with one of these splints, and basically he was unable to get to the jugular vein because of that. He did create a large scar in his left cheek, but so if you've seen Seward being photographed in any kind of post-war photographs, he always has it in profile because he has this large scar in his cheek. Okay, next is hospital gangrene. That's a streptococcal infection, the so-called strep flesh-eating bacteria. It often required secondary amputations and had a 47% mortality. Improved survival was noted when they did isolation of patients with not sharing of sponges, towels, or sheets, or reused dressings and bandages. Now, a treatment was developed called the bromine treatment, where you actually would pipette this caustic agent called bromine onto the thing, and it actually dissolved the gangrene. Of course, this procedure was so painful, it required the patient be given chloroform or ether first in order to do it. But if you go to the next slide, it reduced the mortality of hospital gangrene to something like 3%. And this was done by Dr. Middleton Goldsmith in Louisville, and he treated over 330 cases of this. And as I said, he reduced the mortality to 3%. There's the hospital he worked in. He published the findings in 1863. And there's the book, the report that he published on hospital gangrene in 1863. And arterial ligation was another advance in the American Civil War, and we've already talked about the use of the tenaculum and the general hospital. So these were, once you were transported off the battlefield to the cities, you went to a general hospital. They were located behind the lines. The Union had 204 with 130,000 beds. Confederates had 154 of these things. The average Union census by war's end was 71,484. And you can see that one is Armory Square, and that's the inside of one of these. Armory Square is located where the Air and Space Museum is today. There indeed, during the Civil War, was an armory there. And so they set up one of these hospitals called Armory Square. And Walt Whitman was one of the people who went to Armory Square. Now, Silas Weir Mitchell, this was talking about another medical advancement of the war. He was the director of Turner's Lane Hospital in Philly, specializing in treatment of neurologic injuries and diseases. He was known for the rest cure. Now, if you've ever heard of the term phantom limb pain, which patients who have amputations feel pain in the amputated limb, that was coined by Silas Weir Mitchell. There's a thing that we call complex regional pain syndrome. That's this severe pain syndrome and people who've had injuries to extremities. That also was coined by Silas Weir Mitchell at Turner's Lane Hospital in Philadelphia. So he did a lot of really groundbreaking work there. Interestingly enough, he lived till far after the war, and he said his assessment was, we had served faithfully a great cause as earth has ever known. We had built novel hospitals, organized an ambulance service as had never been before been seen, contributed numberless essays on disease and wounds, and passed again into private life, unremembered, unrewarded servants of duty. So that was his assessment of what the Civil War surgeon did. So at the end of I always say at the end of my talks, why do we do this? We say, and my favorite guy to quote on this is Churchill, who said, the farther backward you look, the further forward you see. We will take questions.
John, this is Terry Zerwick. Can you hear me, John?
I can.
Well, thank you very much for your talk. Appreciate it. As you know, my great-grandfather was assistant surgeon for the Pennsylvania Bucktails. And I wonder if you could briefly describe the distinction between the assistant surgeon and the surgeon himself.
Absolutely.
What was the assistant surgeon permitted to do? For example, could the assistant surgeon perform an amputation? Talk a little bit about the distinction between the two and their duties, how they interacted.
I'll be happy to. Okay, so by and large, especially in the Union Army, each regiment was supposed to have one surgeon and two assistant surgeons. Our surgeon was a major. Assistant surgeon in the Union Army was a captain. In the Confederate Army, they could also be lieutenants. Generally speaking, the guys who you would start off as a assistant surgeon. So as you had more experience, you would then get promoted to surgeon. Although obviously at the beginning you had to have surgeons, and those were presumably people with more experience and more ability. The way it was supposed to work is the amputations were indeed done by surgeons. Sometimes, of course, that depending on logistics and volume of cases, you may have to have assistant surgeons doing amputations as well. But by and large, it was supposed to work that way. One of the things assistant surgeons did were assisted surgery, keep the records, and records amounted to what procedures were done and that kind of thing, but also burial records, that kind of thing. In addition, sick call was often done by assistant surgeons, sometimes by the surgeons, but assistant surgeons would do sick call. And in the Letterman system, what they would set up were called field dressing stations. The way the Letterman system worked was you would set up a field dressing station, presumably more than 100 yards behind the lines, which would put you out of musket range, but didn't, or 300 yards, but that didn't always work out. And so the guy assigned to the field dressing station would typically be an assistant surgeon also. Of course, in the general hospitals, you had surgeons and assistant surgeons as well. And again, a surgeon would be in charge of a whole ward, whereas an assistant surgeon would be in charge of smaller numbers or would be assigned to do things like change dressings, that kind of thing, you know. More menial tasks in the hospital that still would require a doctor, but would not require a surgeon. A guy with the rank of surgeon who would be there to do surgical procedures, if you will. But things like changing bandages and changing dressings and that kind of thing would be more the purview of the assistant surgeon. Does that answer?
Yeah, thank you, John. Just a quick follow-up question, if I may.
Sure.
Did the assistant surgeon actually go out into the field? Was he close to the battle lines?
Well, like I say, he
perform triage there and things like that?
Yeah, the field dressing station is where they would go. One thing Civil War surgeons would not do is go onto the actual battlefield itself during the battle. And that's for obvious reasons. Remember, you had, how many of these guys did you have? You only had in the entire Union Army 12,500 surgeons. So you didn't send your surgeon out onto the battlefield where he might get shot or wounded or killed. Some did, but the idea was they didn't go onto the battlefield itself. So I would see in reenactments and years ago, people starting out doing medical where they would go out in the field and they would start treating people out on the field, new guys in reenacting, and I would always have to yell at them to get off the field because it's not accurate. You didn't go out onto the field and do, even guys who were trying to do amputations out on the field, that was not done. The bullets were flying, they were not doing amputations on the field itself. And they tried to limit doing amputations to the field hospital, not the general hospital. So, not the field dressing station. So the field hospital could be in a tent or in a gully somewhere, but it try to be in a building like a church, a school, that kind of thing.
Hey, John?
Yeah.
Paul Severance here, real quick. When you were talking about the amputations, I noticed you didn't talk about resection.
Well, I didn't, because we didn't do a lot of resections in the field. I happen to have a chainsaw, or Golgi saw as they're called, and some were done. I'm not going to say that none were done in field hospitals. Some were done at Gettysburg. Actually, one of the guys got in trouble for doing one because they take too long. But what Paul's referring to is a procedure called a resection, where you would, instead of amputating, you try to salvage the limb by literally resecting the damaged portion of bone, and then approximating the two ends of bone together, which would result in a shortened limb, which was less functional. So in a lot of ways, it was not as good to do actually a resection, which is one reason they didn't do a lot of them. But the other reason, as opposed to less than 15 minutes to do an amputation, a resection could take 45 minutes to an hour. So it just wasn't practical. And but we do have these things. They're called chainsaws. That's how you do it. It actually has, on one end, it has like a needle-like device to thread it through to the other side. And you literally, like a chain, that's how you resect the bone, with the sharp chain. And then that's how you resect the bone. But yeah, and again, they were done, but not the primary mode of amputation.
John, the mortality figures for the soldiers, like for every soldier that died from a wound, you had 2 or 3 that died from disease.
Right.
Now, when you look at the subset of Black soldiers, that was 3 to 4 times that. It was like 7 to 10 died from disease.
Yeah.
Do you have any idea why that was so? And one other quick follow-up.
Yeah, I would guess one of the reasons is that, for one of the things, they deployed a lot of the Black soldiers in the Deep South, thinking that they would be resistant to things like malaria, because coming from Africa, and that indeed was not the case. So these guys would inordinately get that kind of thing. And frankly, probably the medical care that they got was not as good in many cases as the white soldiers. I told you that, the Black regiments had white surgeons. They, in many cases, would not serve, like I said, with the African American surgeons, and they were plenty of racists in the medical ranks as well, in the Union Army, just like the regular guys were. So I think that there was some of that going on too.
And the other thing that I would comment on is, you mentioned the Sanitary Commission, but they also had something called the Christian Commission. The Christian Commission did some of the same work as the Sanitary Commission. And I think one of the Chamberlain brothers was with the Christian Commission.
He was.
And they used to have a gigantic truck or machine for coffee to take the place of alcohol.
They had a coffee wagon. Absolutely.
The coffee wagon, right. And they also felt that sometimes they can comfort the dying soldier because of something, I forget the author's name, but I think that the book is called This Republic of Suffering, to help the soldier have what they call the good death. And that sounds like an oxymoron.
That's Dale Gilpin Faust, who is the former president of Harvard.
Right.
Who is but in her academic life was a Civil War historian, primarily writing about Southern women, but one of her more famous book was the book you're talking about death and dying in the Civil War. Yeah, I didn't mention that. I probably should have. They didn't really do the actual medical stuff as much as the Sanitary Commission did, but they certainly, as you intimate, provided supplies, and they certainly supplied a lot of Bibles to these guys and pastors as well. And I should mention the Sanitary Commission actually provided some surgeons too. The Christian Commission would provide chaplains for the guys. So, and there was both the Eastern Sanitary. I didn't want to get too much into the weeds of it, but there's also the Western Sanitary Commission that was started in St. Louis. So there are actually two different sanitary commissions for the two different theaters of the war.
Hey, John, it's Bill Benzel, and a question for you. When Booth and Harold arrived at the home of Dr. Richard Stewart, Clydell, the narrative is that Dr. Stewart refused to provide Booth with any sort of medical assistance, saying that he was only a physician and not a surgeon. In your opinion, was that an excuse, or was that kind of the customary practice of the time, that if you were dealing with a broken bone, you needed you needed to see a surgeon?
No, that was it. He was blowing smoke at Booth, because if you recall, he went to Dr. Mudd first, and Dr. Mudd set his leg. Dr. Mudd was a physician, a surgeon. The term surgeon back then only applied to military doctors. That's what a surgeon meant back then. There was no distinction primarily, certainly at the time of the Civil War, made between surgeons and physicians like we do today. Most people were just doctors who did both. So he must have been blowing smoke at Booth. That was the guy who's related to General Lee, wasn't he, Stewart?
Yes.
Yeah,
even my current Maryland medical license says physician and surgeon.
Yeah, exactly.
And I'm not a surgeon.
That's right. And so no, he was telling the story to Booth, I guess.
That's what I thought. Great presentation, John.
Thank you. More questions?
John, I'll share with you a brief anecdote. This is Terry Zerwick. My great-great-grandfather, I think it was in the Wilderness Campaign or Spotsylvania, he had his sword shot off of him, which is very confusing to me. Why would he wear a sword when he was being a doctor? But I have correspondence that says his sword was shot off of him.
Well, we have medical swords. Most of the time they were just worn like for parade ground and that kind of thing. And if you see a lot of these posed pictures, you'll see a guy wearing a sword doing an amputation, so you know it was a posed picture. But if he was like on the march or something and not operating, conceivably he was wearing his sword, because they definitely, boy, I know some guys who have originals. I have a repro, but if you get your hands on an original medical officer sword, they're worth a lot of money. It's funny because there's a book which has all the just a guy just edited the letters of one of the bucktail surgeons. I can't remember the guys. I have the book, but there's a book that just came out with all the letters of one of the bucktail surgeons. He was at Gettysburg.
Huh.
But it wasn't your ancestor, but it was a guy who served with him.
No, my guy was not at Gettysburg.
Oh, well, the bucktails were there, but
Yeah, the bucktails were there. Yeah.
yeah, he was there's a church in town that he was at.
Pardon?
There was one of the churches in town on Chambersburg Street that he was at.
Hi, this is Don Mack. I had a question. I've been reading a book about the woman at City Point and all the different jobs they did. And one of the one of the jobs was running these diet kitchens. I was just curious why it was called a diet kitchen. I mean, did they provide different food for different maladies or?
Yeah, I can tell you that I actually covered that a little bit in the talk. They had what they called the low diet and the high diet, based on what we're talking about, the Brownian system, where you thought the system had to be either calmed down, if you will, or stimulated. So their diet was based on that. And so and I even gave some examples in one of the slides. And that's one of the things they did with the diet kitchen. They came up with those different diets. And all the large general hospitals would have that. City Point, of course, being probably the largest hospital complex in the Union. Clara Barton was not at City Point, but she was not far from there. She at one point was at Bermuda 100, which is near Petersburg. And that's what she did there, actually. She worked, one of the things she did at Bermuda 100 was work in the diet kitchen.
John, this is Craig Howell. What can you tell us about one of the more colorful figures of the Civil War, Dr. Mary Walker? It was unusual for a woman to be a doctor. It was unusual for a woman doctor to be in the Union military service, and unusual that she won the Congressional Medal of Honor and later lost it and got reinstated.
Yeah,
what do you know about her medical career?
Yeah, I just heard an interview with somebody who was one of her biographers. And also, we of course have Mary Walker's instruments at the museum. We have her pocket medical, I showed you the pocket kit. We have Mary Walker's pocket kit on display at the National Museum of Health and Medicine. So I get to talk about Mary Walker on my tours. And of course, Mary Walker was indeed the only female physician to have a commission in the Union Army. She had gone to medical school in Syracuse. She actually, she had all kinds of, she was a very controversial figure. Whether or not she was medically competent or not has been a subject of some discussion because she was failed on her exam. Early in the war, they had very low standards. But as the war went on, they had examining boards and fairly rigorous examinations. And Mary Walker actually they flunked her. She claims they only flunked her because she was a woman. They claim she was not competent. She did serve various capacities in the Union Army, though, and did ultimately have a commission. She at one time was put in charge of a woman's prison in Kentucky. She did serve in the field, but there's no evidence that she actually did amputations, that she did treat disease and did minor surgical procedures with that surgical kit, but we have no evidence that she actually did major surgery. She at one point was a spy, and she is the only woman, of course, from the Civil War to win the Congressional Medal of Honor. She dressed like a man, which she did for the remainder of her life after the war. And in the late 19th century, maybe early 20th, they tried to take the medal away. They took a whole bunch of Civil War Medals of Honors away. And they tried to take Mary's away, but she refused to give it back, and she continued to wear it for the rest of her life. And then Jimmy Carter, in his administration, reinstated Mary's Medal of Honor. So that's sort of the brief story of Mary Walker. She's a very interesting, colorful, and controversial character from the Civil War. And if we ever reopen the museum, you can come out there and see her instruments.
Was that Augusta? Is he buried in Arlington? One of the African-American surgeons? I think I know where he is. Craig Howell would know if not.
Yeah, I don't know. Is he in Arlington?
Yeah, yes, he is buried at Arlington.
Yeah,
Yes,
okay.
I think so. Beautiful memorial.
I have a friend, Bob Slauson, who's also a physician, but associated with the museum, who actually wrote a book on African-American surgeons. I think it's the only really good book on African-American surgeons, and it's not written by an African-American now. So now you guys know what Civil War medicine's the true story. They weren't butchers. And what I always tell people is 150, 160 years from now, what are they going to say about the medicine we practice?
What are the main microorganisms that were expressed in the Civil War deaths and injuries?
Well, of course, the number one killer was dysentery. And of course, we don't know. We presume, for you physicians, Salmonella, Shigella, even Yersinia or Campylobacter were probably all present. But since they didn't have the ability to determine that, we'll never know, even viral, how many of these things were. The second killer was typhoid, which we do know about. Now, how many of those were truly typhoid, we don't know, of course. Because especially in the Union Army, they had a thing they called typhomalarial fever. And we do not know what that actually is. We think it's most of those cases were probably typhoid rather than malaria, but it was people who had sort of relapsing fever, we think. But the Confederates, of course, didn't use that. So no such disease existed amongst Confederates because the Confederates didn't use that term.
I believe consumption was the big killer too.
Well, consumption was tuberculosis. And of course, it was not as to the degree that these were, but yes, of course. Tuberculosis was a big killer back then. And of course, that gets its name from the appearance of people who have it, that sallow, thin appearance, consumptive. In fact, that was considered sort of sexy among women to look like that. The consumptive appearance. Absolutely.
And thank you very much, John.
John, thank you,
People are
Kurt.
leaving, but
Thank you,
thank you
John.
very much for a great presentation.